Now, my name's Theodore Chamberlain. I work at the Maleny Soldiers Memorial Hospital, which is a 24-bed rural hospital in a modified Monash Model 5 area. It does what most rural hospitals do. It provides acute care for the community, runs a 24-hour emergency service. I also run a small rehab unit and palliative care unit. And I also run a world-class movement disorder clinic out of a 24-bed rural hospital. And that's actually the team for the movement disorder clinic. So what are we besides a 24-bed rural hospital? We are a movement disorder service. We provide the referral center for the Sunshine Coast Hospital Health Service, a $1.8 billion health service, and the tertiary referral center for movement disorder for advanced Parkinson's disease is a 24-bed rural hospital. If they have a difficulty with a patient in intensive care, they phone us. If they need a patient who requires more care than the tertiary hospital can provide, they refer to us. We are the referral center for a $1.8 billion health service. We look after the deep brain stimulation and advanced therapies from Brisbane. If people need to be transferred to the Sunshine Coast, they come under my care. We run a Parkinson's disease day hospital, and we do home visits and residential aged care facilities for Parkinson's disease. So we do much, much more. Oh, by the way, because I've only got 20 minutes, I'd cut out most of the data and you just get the videos. We do research. We're part of the Duo Global study, the EuroInfo study. We belong to the Florey Institute. In fact, the professor of Parkinson's for Finland came out to Australia, and there was two places she visited in Queensland. One is Maleny, 24-bed hospital, and the other is the Royal Brisbane Women Hospital. So why a movement disorder clinic? Well, one, because it's fun, but it also fits into a theme that I've been harping on for years now. That is, for rural medicine to really thrive, it needs to reinvent itself. We can't just keep doing what we're doing a little bit better. We need to innovate. We need to resurrect rural health. We need to reverse flow of patients, technology, and information from the tertiary centers back to the rural areas. And you can only do that if you innovate. And you will only be paid attention to if you add greater value to the health system. The ethical argument that we need to improve healthcare in rural environments because of equity is a reasonable ethical argument. But unless you add value to the greater health system, that argument is hard to carry weight. So, what is a movement disorder clinic? It's a clinic that specializes in movement disorders, in this particular case, advanced Parkinson's disease. Why Maleny? Because we're a rural hospital, and the advantages of rural hospitals are that we're amazingly flexible, we're amazingly adaptable, and that we build great teams to do great things. We're not stuck in our ways. We can innovate. This is the rural advantage. There's lots of limitations to rural areas, but the advantage to being in a rural area is our flexibility and our adaptability. So why innovate? Listen, this is just a bell curve of growth and decay. Okay, this is natural, whether it's market share, whether it's health economy. What happens is on this side, you have growth, and then you have decay. Now what happens is that Oops. This part of the curve is where most of our health economy sits. I call it the efficiency death spiral. What you've done is you've grown, you grow, and you grow, and then the crunch hits. Money's short, people are short, and so we start having meetings, we start having workshops so that we become more efficient. And what more efficient means, doing more and more with less and less. And how long do you think a system can do more and more with less and less? You burn out the system and you burn out people. So the efficiency death spiral is what's wrong with the health system. And there's only one solution to that, and that's to innovate. And what you do with innovation is, at some stage, you do something radically different, and you go to another growth spurt. The classic example is Apple. Macintosh computers coming to a peak where the market's saturated. And then Jobs does the iPhone, and you're off on another curve. Now, the important thing from the health point of view is that innovation will cost you. It'll cost you time and money for a period until you hit that break-even point. So during this period, that way and that way is a loss to the health system. But when you hit that break-even point, if you're innovative, you're on this curve. If you haven't innovated, if you haven't invested time, people, and money, then you're on this curve, the death curve. So let's talk about movement disorder on the Sunshine Coast. Maleny, we're the hub of the movement disorder. Because we're rural, we're a true multidisciplinary team. We're not a bunch of neurologists in a tertiary outpatients. We're a team that is patient-centric. Because we're a rural hospital, we have access to inpatient acute beds and rehab beds. We do a clinic that sees 23 to 28 high-level tertiary quality patients every week. We've got 2,000 patients on the books, and we've decreased the neurological wait list from 3 years to 4 months for my $1.8 billion health service. Now I always want to be patient-centric. So this is a story of Phil, 10-year history of Parkinson's disease under the care of a neurologist, and he came to us. Now he's got Parkinson's disease, he's got all those symptoms, as you can see by the story, resting tremor, falling. He also has a lot of non-motor symptoms. For those of you who don't deal with Parkinson's disease, these cause a lot more trouble than the shaking. Now this is Phil. How do I set the video off, by the way? Yeah, cool. All right, done. So this is Phil. Phil's son had given up work and is staying with him, but obviously Phil is nursing home bound. Now, he's got Parkinson's disease, the shaking palsy. It's a couple of thousand years old, and the treatment is levodopa, and levodopa is still the treatment. Now, Parkinson's disease affects the whole person, physical, emotional, social, psychological, and that's why a multidisciplinary team led by a rural generalist is so effective, because we deal with all these factors. Now, one of the problems with Parkinson's disease is over time you lose neurological neurons, and so you become less and less sensitive. In the beginning, those fluctuations don't matter, but as the disease progresses, you're either overdosed or underdosed. And you spend your life like that. So what we do in a multidisciplinary way is deal with those problems. Now here's an example of some people
Can you
who've
do
got
that for me?
problems with too much shaking.
Big
That's
as
how
you
they
can.
spend their life. Here's another type of shake. Now, you remember these are all videos shot by me in a 24-bed rural hospital, so the quality of the videos are crap, but you know, the patients are. This is this guy's feet 24 hours a day. Spasm, pain. Now, what can we do about it? One of the things we do is we run a pump. Here's a guy who was in just 6 months ago. This is how he spends most of his day in the nursing home.
Any pain in the back at all? Morning.
He's just amazing.
This is him at 2 days treatment, and he's out of nursing home.
Near him,
Yep.
dressed, showered,
Come back.
come back, everything. Didn't do anything.
So we had Per Oden out, who's done the health economics of this. And by keeping these guys out of the nursing home, we are saving the system lots of money. The other thing we do is we do duodopa. We put a percutaneous endoscopic jejunostomy into people's jejunums and do another form of pump. Here's another patient of ours. This is his day-to-day life. His wife quit work to look after him, but again, he's nursing home bound.
Now,
That's him on the pump.
pass me.
Okay. Nursing home avoidance.
You
Now, as I said, we get referrals. This is a patient that was referred from the major tertiary, ultra-tertiary, what's above tertiary, I don't know, Royal Brisbane's Women's Hospital. This guy's got deep brain stimulation. It's been successful for 5 or 6 years. It started to wear off, and they've rung us and they said, listen, he's at the end of the road. Is there anything you can do for him? And we said, sure, we'll have a go. So this is what this guy looked like when he arrived. Now, technically, because he's had deep brain stimulation that has failed, he shouldn't respond to anything. But again, because we're real doctors, we're going to give people a go, okay? Because we believe in people. We don't believe in stats. So we put a tube down his nose and put him on the pump to see if it'll improve his function. And lo and behold, typical rural storage area, but the idea is to put a Parkinson's patient through a difficult environment where they will freeze, and he does it well. He actually caused me great distress because he got out of the nursing home, went back home, had an argument with his wife, and ran off to the bush. And I had to actually call up the head of the police to actually initiate a helicopter rescue of him because no one realized that once the pump wore off, he would freeze. So I had to get a special helicopter emergency response for him. Now, those patients, we've saved the health system a lot of money. This is a patient who we didn't save the health system a lot of money. She's a high care nursing home patient. Now again, this is all done in a 24-bed rural hospital. So you can imagine her quality of life. This is her on a pump. Now she didn't actually leave the nursing home, but her quality of life is amazingly improved.
Okay, we'll do it.
She was even playing the piano, which she hadn't done for about 5 years.
Turn around when you're ready.
So
Deb.
she's one that we didn't save the system lots of money, but we've really dramatically improved the quality of her life. Now, when I talk about multidisciplinary team, some of you won't understand it. What it is, it's an approach where the patient's care is looked after by a team. Parkinson's disease affects the whole body, so to look after someone requires people who look after the whole body. That includes medication, it includes physiotherapy, occupational therapy, social work, dietitian, diversional therapy. And it's that holistic approach that gives us big bang for bucks. Now here, this is a patient that came to our patients. He's had Parkinson's disease for 15 years. He's on a TDS regime.
Do you want to stand up for us?
And this is as good as he gets.
How do you feel?
He feels sick. Okay. Now, being a doctor, I did very little
Just
for
gonna
him.
go back a bit.
I changed his
And I
medication
wanna
from
see you
TDS
take
to
a few steps
QID
for us.
to
Can
give
you?
him a 25% increase. But what I did do was admit him to the
Okay,
Maleny
that's a
Soldiers Memorial Hospital,
All right.
24-bed rural hospital.
Can you turn it on for us?
Whoops. So, this is him after 2 weeks of rehab. So only a minimal medical change, but getting the diet right, occupational therapy, physiotherapy. Whoops.
Keep walking straight, Adrian.
Okay. Minimal medication change. That's my dining room, by the way.
Turn it on for us.
Now
Stop
we
there,
do,
Adrian.
if people are within close proximity, we do a home
you feel?
program that we modify.
Excellent. I'll let you walk back to your bed. Is that okay?
This is him at a 3-month review, and he's continued to do his home therapy.
Good stuff. Come back. It is indeed, Dad. Yeah.
1 extra pill a day, multidisciplinary team. Okay. Now back to Phil. This is Phil, if you remember, nursing home bound. This is Phil,
That's pretty good.
4 years later.
Excellent.
This man has traveled around the world 3 times. How do I know? I've been rung up twice by customs in various countries wanting to know why he's trying to take these drugs on top of, through the customs. But yeah, we bought this guy 4 years of life, which you can't put money to, and we saved the system 4 years of high-level nursing home. So, why do we do a movement disorder? Well, for one reason, we do it for these clinical outcomes for people like Phil. The other reason is for a larger scale reason. And you'll have to excuse the squash map. I thought Peter Arvier was going to be here, and I wanted to include Tasmania. And I actually got my daughter to do an interactive display, but the technology isn't working. But if you think about Australia, most flow goes from rural areas to big tertiary areas. So the map of medical flow is from rural areas to tertiary areas. If I could do a little blow-up of Maleny, you would see something unusual. You would see a small 24-bed rural hospital which is draining patients from an amazingly large area. We take more patients out of the tertiary system than we send to them. So patients are flowing backwards into a rural area. And if you then look at the linkages, okay, Maleny Hospital, because it's a world-class movement disorder, links to a whole lot of the other areas where we provide clinical and technical service. So what happens is you now have a web that is moving flow backwards. Now my dream is that we will have a revolution, that we'll have a revolution in innovation, where you'll have some little place that will specialize, let's say in chronic obstructive pulmonary disease, and not only treat its local community, but treat the community across the plain, over the mountains, or over the next set of mountains, and develop its local network with nodal connections. And pretty soon, if each individual person chases their dream and produces a quality health, localized health service with nodal relations, then the map of health will be a pile of interconnections. In other words, we'll shift the paradigm from the tertiary drain to providing high quality care where people are. Now, what I expect is a nodal system to look like that, where you have areas of expertise. Now, why is that important? It's important for the reasons I said before, that the paradigm of equity is important, but until we embed healthcare where it should be, until we innovate, we will just be on the efficiency, death spiral. Now, this is the Maleny Soldiers Memorial Movement Disorder Clinic, and that is a lady who was a famous painter. She hadn't painted for 15 years. In fact, she was bedridden for 5 years. And now she is out and painting. And that's, again, back to the first reason. What we do is for our patients, but by innovating and producing excellence, I've got 5 minutes to go, we can revolutionize healthcare. Okay. Now, this is my real message. Now, my real message is not that we've done this funky world-class movement disorder clinic in Maleny. My real challenge to everyone here is for each one of you to go back, find that thing of quality that excites you, develop expertise in it, and use the advantages of rurality, which is to develop a great team, to develop networks, and then to develop nodal relationships with the other like-minded people, so we can cover the map with healthcare from the bottom up. So this is what I want. I want the revolution of innovation and quality from the rural environment, led by the rural environment. Thank you. Any questions? Yes? The funding? This is not the most important thing. So we built the movement disorder clinic because Tony Tampiappa, who's a geriatrician, had a great idea for multidisciplinary clinic. What happens is all these geriatricians have volunteered their time. All the allied health, I've stolen their time for rehab. There wasn't a single business case or an extra bit of funding when we started this. Now that we've become very successful, we've got some part-time funding for a PD nurse and things like that. But seriously, we built this out of nothing.
Thank you very much for the talk. Very, very inspiring. My name is Sunny. I'm a GP working in a hospital. So are you saying that you are you get patients sent to you who could not be treated in Brisbane, for example, who are not local to your area, actually come and get treatment in your hospital?
For all the health economists here, close your ears. Yes, we take people out of scope. No, listen, I can use the tertiary hospital for the for the pumps. I'm obviously in a 24-bed hospital. I don't do very many gastrostomies. So we refer to the tertiary hospital. So we send them down for a day procedure and bring them back up. Yeah. Well, there's a couple of different levels to that. So one, because we're so successful and because the model's unusual, we have a preceptorship arrangement. So lots of advanced fellows will come to spend a day for us. A lot of the neurological registrars will give up their time voluntarily to be with us. Okay, so that's one answer. The other answer is the first time we turned up at a movement disorder conference, International Movement Disorder Conference, it was really like, who the F are you? Because I'm not a neurologist, and Tony's a geriatrician. So our original greeting in that was not very high. But we have produced data, okay? We are good. We have the biggest series of advanced therapy besides DBS in Queensland. So now when we're at the movement disorder, I go, excuse me, Mr. Neurologist from King's, but I disagree. My series says this, this, and this. And they listen. Okay.
I love the model, I love the commitment of the whole concept known as reverse flow. What happens when I've got Parkinson's disease in a few years' time and you've retired? So what the question is really about, how do you sustain something in a small area when you need special skills, a group of specially skilled people, all with an interest in that area? How do you create the sort of the succession planning and the sustainability?
This is very important. There is a different skill set involved in innovating and developing something and maintaining it. And, and both skill sets are important. I know. Listen, I'm an innovator and I can get this up and running. The most important thing now is to make it sustainable. So what we did was we got this underneath the radar with a lot of goodwill. We've got the data, and now we're becoming mainstream. We're doing the business cases, and we're doing the succession planning. And hopefully in a couple of years, I will pass it on. Thank you.